Okay, shall we begin? It's really, really lovely to see so many people coming today, and we genuinely appreciate your time. I realise it's probably lunchtime for most of you, and I'm sure you don't get that long for lunch. So thank you very much for joining us today. For those that don't know me, haven't met me before, my name's Katie, and I head up the customer success team here at PKB. Customer success, for those of you that work closely with us, you'll know that's our on the ground staff, our project managers and implementation specialists that I'm sure you all have met and worked closely with. I thought it'd be nice, just because we've got so many of our customers here today, if those members of customer success that are here just waved and said hello, and just reminds everybody which customers you look after, just so that your customers can see who you are in case they haven't put a face to a name in the past. So Suzanne, do you just want to say hi to any of your customers that might be here?
Yeah, hi, I'm Suzanne. I'm not Mohammed, contrary to what the screen probably said. Definitely not Mohammed. Hi, nice to meet you. I'm Suzanne, and I work with the Essex team that are here. I've seen some of the names I recognise popping in, so.
Brilliant, thank you. And Sue?
Hi, I'm Sue, and I work with Mid Yorkshire Teaching Trust and South West Yorkshire Partnership.
Brilliant. And Jihan?
Hi, it's Jihan from London team. I look after oh my goodness, sorry. I look after Barnet, Enfield and Haringey Mental Health Trust.
Lovely, thank you. And Grace?
Hi all, so I'm Grace. I am the regional manager of the South, so I oversee lots of the projects going on in the South, but working directly with Sussex mainly, variety of trusts there. And it's lovely to see people join in.
And Katie?
Hello, I'm Katie. I work in the London team, predominantly looking after North West London. Lovely to meet you all.
And Nikki?
Hi everyone, I'm Nikki. I'm part of the Northern team and I look after the Midlands Partnership.
Thank you. And Marie?
Hello, so I'm Northern team and I look after Holston Vale, which I can see quite a few faces here, and Cheshire, which I can see a few faces too. Nice to see you.
Brilliant. Thank you. Sarah Smith?
Hi everyone, I'm Sarah Smith. I work in the London team and I look after the North East London programme.
Thank you. Olivia?
Hi everyone, I'm Olivia. I work with our teams in Wales, which include Helder and Swansea Bay, who I think we've both got with us today.
Excellent, thank you. Gillian?
Hi, I'm Gillian. I'm in the Northern team. I'm newer in the team, so I'm supporting across a few different projects, not leading at the moment. Nice to see everyone.
And Freya?
Hello, I'm Freya. I work in the Southern team and I'm working with East Sussex, Queen Victoria in Sussex and Dartford as well. So,
brilliant. Thank you. I think that's all of our success team stuff that I can see. There might be a few others lurking without their cameras on, but hopefully your customers can put a face to a name, and that's great. Thank you. Okay, so moving quickly on, we've got an awful lot of people on the call today. As I said, thank you for your time. We've got a presentation from Dr. Sam Finnikin from NHS England, who's going to be telling us all about decision-making tools and decision support tools for patients, how they came about, what they're used for, kind of the reason behind them, and lots of information on that. Because there are so many people on the call, normally I'd say please do jump in and ask questions, but I think it could end up a little bit chaotic if we do that. So if people wouldn't mind staying on mute whilst Sam does his presentation, and we'll have time for questions and answers at the end. And then we're going to have a presentation from Grace from PKB about how these decision support tools are looking in the system, and how you can use them and what workflows they can go hand in glove with. So if I hand over to Sam, thank you, Sam, and we'll look forward to seeing what you're going to be telling us.
Thanks, Katie, and good afternoon, everyone. I'm really pleased to be here talking to you today. So as Katie says, I work for NHS England. I'm actually a GP for half the week as well. And I work with the personalised care team at NHS England. And one of our roles is to support clinicians and patients having better conversations about decisions they make about their healthcare. And that's why we've embarked on a project to produce decision support tools that I'm going to tell you about today. And the purpose of my presentation is to introduce the tools, what their purpose is, how we produce them, give you confidence in the tools, and a little bit about the production process. And then, as Katie says, Grace is going to talk about how they integrate into PKB. So I'm going to just bring up my slides. Forgive me, I've got a little bit of a cold if I'm a little croaky. Hopefully you can see this all right. So these tools we produced, we started this production 18 months, 2 years ago. And the first lot of tools we started to produce with the Winton Centre for Risk Communication, was based at the University of Cambridge, and more latterly we're working with NICE on tools. And the one on the right there, that's the start of the knee osteoarthritis tool. I'll talk you through the different topics we have a little bit later on. So why are we doing this? Well, as a national team, as NHS England, we are looking to implement the person-centered care, the personalised care model, which has been around for a few years now. And one of the key facets of this is shared decision-making. So that's patients and clinicians making decisions together in a collaborative way to making high-quality decisions. It's something that is fundamental to good care, but it's not universal. That's why we're still trying to get it more uptake of shared decision-making. And it supports lots of things that you'll be focusing on within your systems at the minute. So it's a really pivotal part of consent. Consent starts with the decision-making process. And if you get the decision-making process right, then consent is much easier. And actually there's this process of two-stage decision-making that we're hoping that elective pathways are moving towards. So it starts with shared decision-making and ends with the signing of a consent form. And a decision support tool is a way of evidencing and supporting that process. When it comes to elective care recovery, which I'm sure is on the forefront of a lot of people's minds, it's important that when people are on a waiting list or are put on a waiting list or even have a procedure, that it's the right procedure for them. A lot of evidence to suggest that a lot of people get procedures that actually they don't want or need. And shared decision-making is a way of ensuring that people get the right treatment for them. And so in terms of looking at our elective list and waiting list validation, shared decision-making using decision support tools and the skills that go along with it can help ensure that the right people are on waiting lists and the right people are getting procedures. From a clinician, a provider point of view, shared decision-making is also an ethical, legal and moral obligation. NICE and the GMC a couple of years ago produced guidance on decision-making, which put shared decision-making right at the forefront of what we should be doing. So that's why we're focusing on shared decision-making and decision support tools as a way of facilitating that. So very briefly, just so everyone's on the same page, when I talk about shared decision-making, I'm talking about the clinician and the patient coming together to make a decision, with both parties bringing their own expertise to the conversation. So the clinician is the expert in the diagnosis, the causes, treatment options, and the outcome probabilities of each option. And the patient brings their experience of their illness, their own individual circumstances, their own individual preferences, values, attitudes to risk. And actually combining these things to make decisions is not a simple thing. We know there are a lot of challenges in getting this done in practice, and I won't rehearse those now, but the point is that the decision support tools, which some people may know as patient decision aids, help in a number of ways. Firstly, they bring the evidence base to that consultation without to go to multiple sources, and they communicate it to the patient and the clinician in easy to understand ways. So the reason we work with the Winton Centre is that they have expertise in risk communication. A lot of what we're doing is communicate complex risks in a simple way. But it also ensures that all the options that are available are discussed or brought to the table. And all the tools have an element of trying to get the patient to contribute something to the discussion about what's important to them, what outcomes are important, what problems they're struggling with. And sometimes patients find it difficult to bring these to the conversation, and decision support tools help that process. So NICE has produced some standards on the production of decision support tools or patient decision aids, and the ones that we produce meet these standards. But they also, and it's quite an important point, are pains to point out that a decision aid doesn't advise people to choose one option over another. They're not intended to change the outcome of decisions one way or another. And also, they're not intended to replace good quality conversations between healthcare professionals and patients. Instead, it's in the name, isn't it? It's all about supporting that process, hopefully making it easier for clinicians and patients to have those conversations. If implemented in the right way, they can even streamline the process. So allowing patients to be more prepared for consultations, having time between consultations to think about information and communicate information in a more efficient manner. And there is quite a lot of evidence that using tools can help. Sorry, that's gone the wrong way. The computer's on a go slow. I don't know why. Great. Apologies for this. It's taking about 5 seconds to react to everything I tell it to do.
We can see slide 4 changing into 5, if that helps.
Right, and we're on 6 now.
Ah, here we go.
There we go. Right, less responsive than my children. So, with the evidence suggests that if we use tools, people are more knowledgeable, they feel better informed, they're clearer about their values, and probably more understanding of their risks. And importantly, they achieve decisions that are more consistent with their preferences. So these tools we've produced they're not easy, actually. One of the reasons why we as NHS England have done it is because it's quite complex to produce a good quality tool. And so there's no point in all the systems across the country producing their own tool when the evidence base is something that is universal. So this slide might come across quite small, but really what I'm telling you here is that there is a process. The process involves partnership with the right people. So it's not just clinicians, it's also patient groups, charities, clinical leads, both within NHS England and Royal Colleges and out with, but also what we call through the process normal people. So this is not experts in particular things or expert patients, but people who will be using the tools in clinics, and so people who we tested it with and got feedback from to make sure that they were meeting the needs of the users. The topics that we've covered are ones that are priorities in terms of NHS England for all of the time. So they're often high volume, low complexity procedures, things that you might have come across with waiting list initiatives and things like that. And the Winton Centre are the experts in the risk communication, but they also work with graphics people to make it all look pretty. There, we're doing for time. I'll just talk you through an example of one, although when we see the example from PKB later, we'll notice they've taken the essence of the tool and slightly changed it to make it electronic. The ones that we've produced, which are freely available, and I'll show you where from later, are PDFs, but clearly we need to be looking at different ways to communicate with people as well. But I'll talk you through the PDF, and they all have roughly the same kind of structure. So they're very clear about what the decision is about. So this one is about making decisions about Dupuytren's contractor and who it's for. And the idea of the document is it guides people through it. They can use it all in kind of a linear way, or they can jump to the bits that are relevant to them, use it as a reference document, or whatever works for them. And all of them have an element of information behind the condition and the procedures as well. Although this goes beyond a patient information leaflet, and I'll point out where that kind of happens. they talk through the options. As I say, one of the most important things with decision making is making sure the patients are given all the options and have them available to them. And these might be options that won't be available in all settings, but given that patients can choose where they have procedures, it's important that they know that other options are available. But they're all options that are approved for provision within the NHS. So, for example, here you've got needle fasciotomy, surgery, or doing nothing. And doing nothing is always an option, although one that's often not discussed. With all the tools, we ask patients to think about what's important to them, as I said, and then they've got these interactive ways of documenting it so that they can then bring that to the consultation, and hopefully clinicians can use that within the consultation. We call this preference elicitation. And then one of the key things about decision support tools is it puts the procedures or the options side by side and compares the outcomes. So this is looking at the outcomes of the different procedures for Dupuytren's in terms of the angle of the finger afterwards. It also says what happens if you do nothing. And then the risks are laid out, and again, compared across the options, which is a really important part of the consent process. We know that litigation about poor consent costs the NHS millions every year. And one of the problems is poor communication and documentation of risks of procedures, and decision support tools are a way to ensure that that is done properly. And then the tools will have extra information about the options, about the natural history of conditions, and sometimes extra things like this one's got some stuff on pain relief, and some bits about the epidemiology. And then there's further resources and information about how the tool is produced, and a page on the tool where people can write down important information to them, whether it be appointment dates, questions they want to ask, medicines they're on, things like that. So when these are produced, they're extensively tested with patients, and our team that tested these tools from the Winton Centre wrote down some quotes, things that people said. And a lot of people were very impressed with them. All of these weren't used by people in clinic, but a lot of people said, I wish I had got one of these when I made my decision, or, this is the kind of thing that we would find useful. It's clear, and it gives those patients more empowerment and autonomy over the decision that's being made. I won't go through all of these. So the topics that we have available and are in the pipeline are here. I'll just leave this up for a bit longer because it might be relevant to some of you working in different clinical settings, and you can fix on the ones that are relevant to you. The ones in italics aren't yet produced. We've got 6 more coming out the end of next month, or this month, next month, not too long anyway, and a few more in March, April next year. But the ones in normal text are currently available already. And when I say they're available, they're sitting in their PDF form on the NHS England website under this decision support tools. There's a QR code there if you're interested and want to scan it now. And as Grace will talk about soon, the PKB have taken these tools and run with them. The important thing now from our perspective, we're confident that we've produced high quality tools. We're confident that there's an evidence base that using these helps. What we need to do is make sure that people are using them. And anyone who's tried to implement any change in the NHS knows that it's not easy. But we think the key is trying to get them integrated into patient pathways in a way that is seamless and doesn't require a clinician to print off or email or push a button that gets it to a patient. So something that's systematized rather than requires individual action is probably the best way of ensuring that all patients get the opportunity to use these tools. Alongside these tools, it's important that clinicians are aware of them, know what they are, what they're for, and also if they feel they need to, have more training in shared decision making in order to allow them to fully utilize these tools. But that's probably another talk. So I will leave it there. It's my 20 minutes, I would think, pretty much. My contact details are there should anyone want to follow up with anything, and just let me know. But other than that, I will hand back over to Katie or Grace, whoever's picking up the baton from here.
Thank you, Sam. I think that was really informative and great slides as well. So thank you for that. That's really useful. I think off the back of that, there's just, certainly in my mind, there's absolutely no doubt that decision support tools are incredibly useful for both patient and clinician, and certainly the right thing to do. And I think that's why it excited us so much in PKB, because you're talking about person-centered care, putting the patient at the center. And those of you that have worked with us for years will really understand that that is exactly PKB's mission statement. And what we've always wanted to do is put the patient at the center, involve them in decisions, empower them. And it's so wonderful to see NHS England have gone to such lengths to do that, and that we've been able to take those and integrate them, which is brilliant. And hopefully, as you say, be really, really helpful for everybody that I know is thinking at the moment about their elective care pathways and how they can improve those. So great stuff. What we'll do in a moment is we'll just show you, as Sam was saying, how these look in PKB, and Grace is going to do that. But before we do that, I wanted to open up the floor to see if there were any questions from people on the call, any of our customers, to Sam, around anything at all, really, how these have been developed, if you had any sort of questions or anything at all. I'll do my best to see if you raise a hand. Ben Foster from Mid Cheshire.
Hi, yeah. It's just, I might have missed it, but so how many are there, and what specialties does it cover? Like, obviously you've just demonstrated one for a specific specialty. Is there a suite for various specialties, various conditions, and what's the sort of scale of that, if you like?
Yeah, thanks, Ben. There was a slide that did have the different tools we have. That currently there's I think there's 12 on the website. The number changes slightly every now and then. There's 4 in orthopedics. There's tonsils. There's cataracts and glaucoma. There's AF. There's a few. They're kind of scattered, and there's more coming. So there's another 6 or 8 coming in the next couple of weeks on hernias, gallstones, birth choices. So depending on where you are and what your interests are, there might be one that suits you. But because there is quite a lot of work goes into producing them, we're having to do them. We're prioritizing, do them in a step-by-step process. So they're not covering everything yet, but they're there. Chloe, my colleague.
Oh yeah, brilliant. Yeah,
I've got the list there at the minute.
Yeah, I mean, they're fantastic. They look great. I suppose for me, it's just directing them into the right clinical people at the trust. Do you know what I mean? And with it being a varied thing, if I've got a list, I know who to target. That's also that's really helpful. Thanks very much.
Yeah, brilliant. And thanks, Chloe. And Jane, yes, the chronic primary pain is one for the new year.
Thank you. Joanne from PKB, I think you've got a hand raised.
Oh, sorry, Katie, that was an accident. I didn't realise I had.
That was a stray hand. I wonder, Sam, if I could ask a quick question, and that was how, what's the logic behind which condition area is chosen next? Is it literally just who you've got free to help with them at the time, or are NHS England following a specific sort of list?
It's a good question. There's a number of things that come into it. Firstly is what are the priorities of NHS England and systems at the minute? And because a lot of emphasis is on elective care pathways and waiting list, that's why there's quite a few on things like hip and knee OA, Dupuytren's and cataracts, and there's high volume, low complexity procedures that we think that they'll particularly benefit. Others, so we've got 2 on sodium valproate because they came out of a review on safety of sodium valproate, and there are a lot of things that go into it. We need the clinical expertise, we need the right guidance there, and we need there needs to be a suitable decision. A lot of topics are brought up, but actually when you dig into it, there isn't really the evidence or the options or both to allow a decision support tool to be produced. So it's quite a complex process, and there isn't a simple answer, but there's multiple things involved.
Thank you. Martin from PKB, is that your hand? I can see it.
Yeah, I was just curious, how are they tested and validated, like to make sure that they, the tool is doing what you want it to, actually achieving the outcomes?
I mean, so tested is easy. The people who produce it go out and sit with people or do it virtually, and they have a kind of a talk out loud process. So they let people look through it, talk out loud, say what they think, record it, and then iterate. And they did that with people with low health literacy, people with English and not the first language, people with the condition, people without the condition, to try and get a broad variety of responses. Validating is quite interesting because one of the problems in this area is what outcomes do you look at? Because we're not trying to change the decision. We might change the decision, and evidence suggests that people tend to choose overall less intervention, which is one of the good things about these things, because if people don't want a procedure, they don't get it. But we're not trying to influence that. So actually measuring outcomes from what decision is chosen isn't really a helpful approach. There are ways of looking at it. You can look at decision regret, you can look at involvement in decisions, but they're actually quite complex and expensive to do research in that area. We don't have that budget. What we're really after is more of a narrative, a qualitative feedback. So if people use them, we want them to tell us what they think. Are there things that can be improved? Do they work? Do people like them? Do they help? That's the kind of feedback we really want, so that we can ensure that we're doing the right thing.
Cool, thank you.
Thank you. Thanks, Sam. I don't see any other hands up, so I think we'll move across to the PKB part of the presentation, and I shall hand over to Grace, who's our Regional Success Manager for the South. And Grace is going to very ably explain how we think these tools, or show how they look in PKB, and how we think they can fit really well with the some of the other workflows that I know that our customers are using around waiting list validation, e-meet and greet, and various other initiatives. So I'll pass over to you, Grace. Thank you.
Perfect. Thank you, Katie. So let me just pop up my screen here. So that should be all up for you here. So exactly as Katie mentioned, we have been working very closely with Sam creating these on PKB, but ensuring that they link in nicely along with elective recovery and in with workflows, which we know are a priority for trust at the moment, which you are actively looking at to support patients. So it's not having them stand alone and thinking, how is this solution going to work on its own? How do we pull it into the bigger picture and really make it a long, lovely workflow and pathway for that patient to ensure that they are making the right decisions for themselves, but also they get all the information, they linking it into their waiting well and everything else. So we've got just a workflow here, and this is something we can share afterwards. I'm not expecting everyone to digest it now and do a quiz and answer at the end. It's just that this is our overview of how we can see this happening within linking in with e-meet and greet, and then moving on to our waiting list validation afterwards from there. So what we can do for patients and what we can work on around with this pathway is looking at how can we promote this shared decision aid within PKB. At what points of a patient's care can this be promoted, and can this be pulled into their workflow? So one way that we can do it is looking at e-meet and greet. And if anyone who isn't familiar with this pathway, it's very much a referral pathway. So when patients are referred from a GP or from a optician or anybody else relevant, they can be pulled in straight away to a PKB team that then can be given a document to say, we've got your referral, you're on the waiting list, don't call us, we're going to call you when you're ready kind of situation there. And they can receive that in an email form. So they can receive an email to say, you've got a document sat in PKB, you're invited into a new team as well, please go here to view it. But then adding this part of information at the bottom of this email, this footer, can promote shared decision care plans from that Sam has just been through. So it's down here, as you can see, we can add in this wording, giving patients information of what it is, why it's important for them to have a look at them, but then also how can they navigate to it in PKB when they get on the system as well. What do they need to do to get there? So if I just jump into PKB and log in here, this is our test environment, which we can show you them on. And as you can see, the patient has received this letter. They're able to view it within their record, and they can see their referral letter sat there. From here, they're able to explore the PKB portal. The most important thing is then popping in to the care plan section and being able to view the relevant care plan for them. So depending on the team they're in, so say if they're in an ophthalmology team, they can have care plans in here relevant to maybe cataracts or relating to any other part of ophthalmology. I'm not a clinician, so if I say something that doesn't link to a speciality, there's a complete opposite body part, that's my excuse there. So I'm just going to give you that disclaimer as well here. So as Sam was mentioning, we have digitalised exactly all that hard work that NHS England has put into those beautiful looking care plans, I've got to say. So we've digitalised them for patients, so they're able to come onto here, they're able to find the relevant one to them. They can come on and edit it as well and add in all those parts that they want to, but they have been developed and they do look lovely for a patient. They can navigate around, they have quick links in here taking them to the relevant parts of the care plan. So if they need to jump down to different areas, they can do that in here and then they can work through it. What's a lovely benefit of the care plan section in PKB is it doesn't need to be completed all at once. So it's not expecting a patient to sit there, go through this whole care plan in one sitting, answer all the questions, make a decision and go on. They can come on, they can digest it, they can take little bits, go away, think about it, come back, edit it, amend it, put in all of their thoughts, their comments, really take the time to go through this and make the decision that's best for them and best for them as a patient and potentially best going forward in their lives. From this, what we can see happening is that patient really being empowered to look at all of these options, and then when they do get to a point of speaking to their clinician, having an appointment, it's them going with the knowledge behind them. It's them going to it and be able to say, right, I've got, even if they pull it up on their own phone, I've been looking at this option from this shared decision aid and going through it with them and asking them the questions and working together, as Sam said, with the clinician to make sure that the decision being made is going to go forward to support the patient as a whole. So this is one of the care plans that have been created. As you can see, we've got areas here where they can select drop downs. We've got free text areas, all the lovely colours that have been brought through as well on those care plans. Pulling it in with all of the guides and all of the slidey parts here where patients can really add in all of their information. So here's one that's sat for patients. I'll open up a couple more just so you can see how they all are looking and how they look for a patient. So I'll find the one that Sam showed so you can compare the two sides there. It is here. So they create one. So as Sam showed, he showed it how it would look on a PDF, and we have really worked hard to ensure that it pretty much mimics what's on the PDF, but we've just got that digital format to it as well with slight amendments just to ensure it's suitable for a computer, also a mobile phone, tablet, whatever device that patient may be using. So as you can see here, it's got all of the same information, so all about the condition, the different treatment options here, and again, what's important to you. So we've kept the same layout, the same format, all the same information for that patient to be able to view, digest, review, and then take away to their clinical team. They've got the key contacts here where they can add everything into. So that's the kind of starting point for patients. So they've been referred onto a pathway, they've been waiting for an appointment potentially, they're starting to really think about their condition, starting to think about what treatment options are there for me, what can I do while I'm waiting. This can also bring into waiting well as well. So as we know, our waiting lists aren't as quick as we'd hope them to be. So while those patients are on this waiting list, what you ideally want is them to not get any worse while they're there, to ensure that they are doing whatever they can do to make the most of that time, to make sure they don't get completely worse and have to have a completely different set of treatment. So it's being able to add lots of information into our library section here. So information about the exercises they might need to do to keep well, or information on what they might need to do to quit smoking, or if it's something that they need to do to reduce alcohol intake, anything like that. Information can be popped onto here and they can complete and review as well while they're waiting. The next part, thinking about this whole pathway as a whole, is being able to look at how we can validate patients as well. So once they've been on that waiting list for potentially 12 weeks, as in line with the NHS England initiatives, what can patients do to validate themselves? So in PKB, it can be completed in this workflow where, again, after 12 weeks, they can be sent a questionnaire. They can have a questionnaire here that can be sent to them via the trust. Patients can start them and they can come in and validate whether they still need to be on this waiting list. And we have a very simple questionnaire that can be pulled in, that can be confirming, do they want to be on the waiting list, yes or no? And if they don't, what is the reason? And that can be then sent back to the trust, pulled out, reviewed on a mass basis as well. Any questions?
Thanks, Grace. I can see, I was just about to type a reply, but I can see that Chloe Stewart has asked a question. Chloe, do you want to ask a question verbally and we can address it to everybody?
Yeah, of course. So I work really closely with Sam. So we're so grateful that you have incorporated these tools. Thank you so much. And I was really keen to join today just to see them. So thank you, Grace, for doing that. I also work in Sussex, so I'm aware of the e-meet and greet, a piece of work. I suppose it was just where they're housed, really, these decision support tools. And I might have missed the point. I probably did, but I was just, when you were saying, Grace, about looking under plan, I was thinking, would I look under plan for a decision support tool? I just completely understand where you're coming from with that question. It's a really good question and one that we anticipated. So we feel that in PKB, the best place to put these decision support tools is in the care planning section because of the interactive nature of it, because it allows patients to be able to edit it and to interact with it and to save versions of it as they go, and then to be able to share it with their clinical team. There is a possibility that in the future we may consider doing them as a questionnaire, as our questionnaire functionality develops as well. So perhaps in the future there may be more than one option of these, but at the moment care plans is where they sit. And you're quite right that as a new patient coming into PKB, why would you look there? What would prompt you to look there? Which is why Grace, and if you're not familiar with using PKB, there's no reason why it would have been obvious. When Grace was doing that demo, and she suggested that an email notification would go to the patient. So let's use the e-meet and greet example, although it's just as valid in other workflows as well. But let's use that one. So a patient would be referred to the acute trust from a primary care provider, be that optician or a GP, etc. And as they're referred, they would hit the hospital system and they would receive an email to say we've accepted your referral, or we've the meet and greet email, whatever that would be. And at the bottom of that email, and it's quite small on here, so it's difficult to see, is the wording that we've mocked up, but it could be whatever wording that the trust chooses as a footer to the email here, saying your hospital wants to ensure you're explicitly aware of your treatment, care and support options. Therefore, we've provided access to NHS England's shared decision care plans, which you can add to your PKB record, and directing them how to do that. So saying to them, you need to go to care plans and do X, Y, Z. We are hoping in the future to also re-look at our care plan section and see that we can make that a little bit more intuitive for patients as well. But as an immediate out of the box
let patients know how they can find it. We hope having the footer on the email is going to be sufficient to kickstart that process. Does that make sense?
Yeah, that's really, really helpful. And I shall be going back to Sussex to say we need to make sure that we have that in the letter. So yeah, thank you.
Yeah, it's important to have that. We have had patients in the past in other workflows, just to give a little bit of reassurance. So we've had maternity patients in the past on self-referral pathways where with the, I'm going to say this wrong, is it PCSP, the care plan for maternity? I always get those initials the wrong way around, but that have done a self-referral into PKB, joined a team and navigated to care plans and added their own care plan into their record. So whilst we've not used or tested it specifically with these yet, we do have that knowledge. But really great question. Any other questions? Hopefully you can see from the couple that Grace showed, especially as well done, Grace, you managed to find the Dupotrons one that Sam had demoed, so you can see the comparator there. Hopefully you can see how similar they are, and I think there's such great tools, and correct me if I'm wrong, Sam, but I think that up until now the way that they've been utilised is by being on the NHS England website that Chloe kindly linked to in the chat, and patients being told to go to that website, look at them, perhaps print them off and sort of make some notes on them and then take them to an appointment. So I think that having them in this format should hopefully be a step forward.
Yeah, exactly. I mean, people are using them in different ways, but it's just about trying every way to get them to the consultation review. Some people I've heard put them on their consulting room wall so that they can point at them as they're talking patients through. But yeah, I think that whatever works for people, really.
Yes, absolutely. Oh, I can see another question come in. Just bear with me 1 second while I see who that is. Joanne Glover.
Hello. I'm just wondering, and obviously I think this is always going to be the big thing, isn't it, about when you actually put this information in, because I don't know how everybody else is, but coding about patients is generally pretty bad. So, and that's no disrespect, but it's effectively that obviously. So if you take something like Dupotrons, the chances are you'll be referred saying, "I think you've got Dupotrons," and that can start it up there. But actually, for those patients that are referred and there's not a clue at the time, especially as I'm thinking around bowels and things like that, where it's a little bit sketchy. Where is the intention then? Is there any way that if you clinically coded, say that they came out and they did have IBD, that actually there is a way of sort of that patient's got IBD and then the extract would go, right, I've got that code in, pick that up, and that automatically puts in IBD management. Because I'm assuming I know this is obviously a lot of the sort of watchful waiting and ideas about decision support, but there may be things in there as well around just even sort of chronic conditions and such the like that would be useful as well as not just making a decision, sort of like going forward. So what is the ask? Is it always going to be ourselves that always add them and go, right, that's the patient, we know they've got that. How do we pick it up, or how is it intended, to make sure that someone administratively allocates it to that patient's record? Just from a process flow, I'm trying to get my head around it.
Yeah, no, that's a really great question as well, Joanne. Thank you. So what our suggestion is we've been working quite closely with a couple of trusts who are looking at putting patients into not necessarily condition-specific teams in PKB, but kind of slightly broader than that, I guess, as in specialty teams. So you would have maybe, rather than having an IBD team, you might have a gastro or colorectal team, which would cover all conditions in that spectrum. Or rather than having a
hip team or a knee team, for example, you might have a general orthopedic team. And when looking at e-meet and greet, I know that the workflows that we've been working through with Sussex, they're intending to put patients into these, Grace, correct me if I'm wrong, but they're intending to put patients into these sort of specialty teams. And our suggestion would be that, so for example, if it were to be an orthopedic team, that any care plans that related or any decision support tools that related to orthopedic conditions, such as hip, knee, Dupotrons, osteoarthritis, whatever might be developed in the future, would sit in that team in the library, and the patient would add the most relevant one. So they would know that they'd been referred because they had hip pain or they had knee pain, or they'd got a contracture in their hand, etc. Similarly with gynecology conditions or colorectal conditions or neurological conditions or whatever. It is also potentially possible to have all of the care plans available to all of the patients as well, if that were something that people chose to do instead. And the patient would select the one that was relevant to them. Does that make sense?
It does. I'm just thinking around the sort of more generic sort of, musculoskeletal and things like that they start reading something up and adding to it, and before you know it, they've got everything, every single one of those conditions and downloaded it. So it's just, it would be nice if there was a way of, from coding the diagnosis to upload, would be a nice, so that you don't dilute what you're actually trying to, I guess, sort of like support them with, because, I think some of these are going to be really vital in condition specific, but I think generic sort of versions and everything that everyone gets is a little bit more, less likely to.
So currently, Sam, am I right in thinking that a patient would be told, go and look by their primary care practitioner, would be told, go to the website and this is the decision support tool I'd like you to look at?
Yeah. Patients will be sent links often, via text or what have you. And remember that all of these are very clear at the beginning who they're for. So that if people end up with the wrong tool, they'll know straight away. It's in the first line. This is for this people with this condition. Sometimes there's age, so it's either children or adults or both, or genders, because the valparate is only specific for people who have children. So they're very specific who they're for. And some of them are very specific for a condition, such as knee osteoarthritis, not a symptom, knee pain. And some of them, we've got one, for example, on menorrhagia coming up, so heavy menstrual bleeding. So that's not for a condition, it's for a symptom. So they're all slightly different, and they do take a little bit of thought, as you're saying, Joanne, in terms of how they're integrated into the pathway. But, I would refer someone to a hand surgeon for Dupotrons, not for a hand contractor. So the diagnosis I would make then, and I'd refer someone, I'd probably refer someone with knee osteoarthritis rather than knee pain. So, yeah, there's a bit of clinical tie-in with all of them.
Thank you.
And thanks. Great question, Joanne. Thank you. I can see, is it BB with their hand up?
Yes.
Hi.
Hi, I'm Bibi. I work within the e-book services in the Southeast. We deliver service for the community team as well as the mental health patients. I was just wondering have you got specific one for mental health services? How will this work? Will it work on diagnosis? Do we get to choose what we put in PKB? A little bit of clarity for mental health, please.
We've got one on depression coming up next year. That's the only specific mental health one at present.
Thanks, Sam. So what we will do is when that depression one comes out, we'll recreate it in PKB, and then we will give ePUG the option of, would you like to have that uploaded into any of the PKB teams that you've created? So these are not enforced upon anybody. They're not going to sort of be in any PKB sites that where they haven't been asked for.
And then we can talk you through the process of how to upload that care plan template, and help you with that when and if you choose to use it and when you're ready, and take you through some workflows and work with you on pathways that you might want to use that in.
Yeah, sure. I think Sam mentioned earlier on that there is one for surgeon valproate, isn't it?
Yes.
That might be relevant as well. When the time comes, I think it would be good to involve some clinician as well in the process.
Absolutely. Yeah.
Thank you.
Thank you, BB. Anybody for anything else? No? Wonderful. In which case, I'm going to draw us to a close. Can I just say thank you again for spending what's probably your lunch hour with us. We really appreciate it. I hope you managed to eat while you were off camera quickly whilst you were listening. And please do reach out to your success team person or account manager within PKB so that we can help you to understand more about these tools, the NHS England decision support tools, and how you can use them in PKB, and also the other workflows that we have for all of the other sort of issues that we know that you're currently looking at, and how they can tie together. Things, as we said, around elective pathways. So thank you again. It's been a pleasure. And we look forward to hearing from you when you contact us to ask us more. Thank you very much to Sam as well.